Case scenario. A 25-year-old woman presents to the emergency department with a sudden onset of palpitations, dizziness, and shortness of breath. Her heart rate is 180 beats per minute, and she appears anxious. The ECG shows a narrow QRS complex, a regular rhythm, and no visible P waves before the QRS complexes. There is no history of heart disease. Question. Based on the clinical presentation and ECG findings, what is the most likely diagnosis? A. Atrial fibrillation. B. Ventricular tachycardia. C. Supraventricular tachycardia, SVT. D. Sinus tachycardia. Answer C. Supraventricular tachycardia, SVT.
Now let's discuss why this answer is supraventricular tachycardia. We can see there is a presence of regular tachycardia, narrow QRS complex, and no P wave in the ECG. Now let's see regular tachycardia. Regular tachycardia means the distance between RR wave is same, so it's called rhythm is regular. Tachycardia, the heart rate is almost 200 beats per minute. We can calculate heart rate by 300 divided by number of large square. The large square is from here to here, so it almost more than 200. And there is the presence of narrow QRS complex, meaning the less than 120 millisecond or less than 3 small square. We can see the QRS is taking only one small square, so it's called narrow QRS complex. And we can see there is no P waves. The normal ECG is like this: P, Q, R, S, T. There is the absence of P wave. The QRS complex become narrow, and the rhythm becomes regular but tachycardia. So this is the ECG of supraventricular tachycardia. Now let's discuss how this is managed. Suppose patients come with tachycardia in the emergency department, heart rate more than 150. We should assess the stability, we should check the airway, breathing and circulations. The patient might have the complaints like chest pain, shortness of breath, hypotension, or altered mental status. If the patient is unstable, then we should give synchronized cardioversion, immediate synchronized cardioversion. But if the patient is stable, then we can go for vagal maneuvers like Valsalva and carotid massage. But before carotid massage and Valsalva, we should check for carotid bruit. If there is the presence of carotid bruit, then we should not do this maneuver. When we have the medicines called adenosines, we should give rapidly IV push. The central line is preferable, but if we don't have central lines, then we should open wide bore cannula. First dose is 6 mg, rapid IV push, plus with the saline 10 to 15 ml. Then we should wait for, if there is no response, then we can give for second dose, which is 12 mg. If the complex is irregular, it's wide, and we should consider other rhythms. If SP2 resolves, observe an ECG. If persists, then we should call for help for expert consultation. We should call the cardiologist and do further management. So it's all about the management of SVT. Thank you.